Neuro Chapter 7 Principles of Treatment 2 Neuro Rehabilitation. The problems of hypotonia and ataxia. Hypotonia and ataxia are so closely allied that they may be considered together. The bias on the stretch receptors is low, and there is deficiency of activity of the excitatory extrapyramidal system. This is therefore a central and not a peripheral problem. There is lack of synergy and postural co-contraction of muscles around joints so that precision and movement and stability of posture is lost. Equilibrium and righting reactions are slow in being produced and inclined to overreact when they do occur. Movements are inclined to be slow to start and to be jerky and ill coordinated. The physiotherapist has to attempt to redevelop the patient's movements along more normal lines and to keep him aware of normal movement patterns and normal posture and balance. It is most advisable to make use of knowledge of developmental sequence in these cases and to encourage the development of postural stability and coordinated movements along these lines. The patient should progress from a position in which the center of gravity is low and the base wide to the use of positions where less stability is offered. It is very easy to use basic functional positions and movements following the developmental sequence, since this inevitably complies with the low center of gravity and wide base principles of progression. If approximation is applied in the direction of weight bearing, the stimulus already being applied by gravity will be reinforced. This tends to encourage extrapyramidal activity and gives rise to contraction of the muscles supporting the joints over which the weight is being placed. The stimulus of gentle swaying may be applied at the same time to encourage activity in the appropriate patterns. This helps to elicit postural and righting reactions. The patient may be asked to participate volitionally by adding instructions which would be combined with manual pressure in all directions. The instructions would be to hold or don't let me move you as rhythmical stabilization are carried out. These will further encourage co-contraction and combine automatic reactions with volitional effort. Let us take as an example a patient whose condition is so difficult that he is unable to balance the head in a stable posture over the shoulder girdle because of hypotonia. To start with, he would be most suitably positioned into prone line with the elbows and forearms supported over a small bolster of pillows so that he is in supported elbow support prone lying position. If this position is too uncomfortable for the patient because of age or joint stiffness, then a supported elbow support sitting could be used as a substitute. In this position, all that has to be supported by the patient is the head. The physiotherapist can then help the patient to raise the head and, still assisting, can apply gentle approximation through the head and cervical spine while encouraging the patient to hold the position. She can take her support away and reapply it in a rhythmical manner to allow gravity to have a frequent momentary influence upon the supporting muscles, giving them a repeated small stretch. In this way, a co-contraction can be built up, encouraging the patient to be responsible for his own head position. Elbow and forearm supports, figure 7.1. Principles here. Sound neurodevelopmental physiology is also being applied, since control of the head position first shows itself as head lifting from prone lying. Progress can be made by encouraging the patient to lift the head actively, either by using resisted and commanded movements patterns of extension with rotation, reversing with flexion with rotation, or by making the patient follow moving objects with the eyes in appropriate directions. Holds should be given in various positions so that the patient learns to maintain suitable co-contraction wherever the head happens to be. As improvement is noticed, the patient can be encouraged to be responsible for the stability of the upper trunk and shoulders. The pillow support is taken away so that the patient is in an unsupported elbow support prone lying. The physiotherapist may need to apply quite vigorous and repeated compressions through the shoulder and elbow at first to gain some activity, and then may stimulate the action by swaying the patient's weight from side to side and forwards and backwards to encourage excitation of the co-contracting muscles. It may help to use rhythmic stabilizations again here by pressing on the shoulders and commanding hold and don't let me move on you. When balance on the elbow is fairly secure, the patient may be encouraged to rise from complete prone lying into elbow support prone lying and return down again. This requires a remarkable amount of postural and balance control and can be quite difficult for the patient. The patient then can be encouraged to bear weight on one elbow while using the other limb or pushing up on the other hand so that the trunk is rotated towards a more supine position. Balance activities in this situation can be exploited. The patient periodically is lifted off the almost free hand and pushed down on it again and made to hold with rhythmic stabilization. In this way, the upper trunk rotation components are now being involved and becoming more able to stabilize. When the patient has reached this stage, it is time to start encouraging head control with emphasis on the flexor muscle groups. The patient may be in supported sitting position with the head in such a situation that gravity would gently pull it backwards into extension. It can then be worked upon as before, encouraging a hold and contraction around the neck and shoulder girdle region. Trunk stability is most important in these cases, and the rolling activities from side lying are particularly valuable. Spiral trunk rotation should be encouraged and resisted movements of rolling leading with the head and upper trunk and also leading with the legs and lower trunk should be encouraged provided the patient does not show signs of going into abnormal patterns. Static holds and rhythmic stabilizations can also be of value to give trunk stability. The natural progression from here is to make the patient stable in side sitting or in an arm forward support sitting prior to expecting him to be able to take up the position for himself. The continuing progress would take the patient through prone kneeling, kneeling, half kneeling, and standing. In such case, the patient should be encouraged to learn to balance in the position before moving into it unaided and before using the position for functional activities. Patients can be prepared for kneeling by being placed in prone lying with knees flexed. Co-contraction around the flexed knees can be encouraged by giving compression sharply repeated through the heels and lateral aspects of the foot. In some cases, voluntary rhythmical stabilizations may also be used. Half kneeling position can also be adopted in side lying to accustom the patient to the limb position before being put into a difficult balance situation. While the above progress is being made, it should be remembered that we must also be able to carry out skills with free hands and even free feet, and so far the limbs have primarily have been used as weight-bearing structures. Thus, the patient needs help to move the limbs on the trunk as opposed to moving the trunk over the limbs. There are many ways of helping the hypertonic patient with this problem. The above approach will help to some extent since it gives the appropriate postural background. Resisted limb patterns performed against moderate resistance at first quickly and then progressing to slower movements are of value. The emphasis should be made on smoothness and precision of pattern. Reversals without rest are valuable, and starting and stopping with holds in mid pattern are also useful. At first, the trunk should be in a position supported stability, but later progress can be made by making the patient support her own trunk. The range of the reversals may be gradually reduced and the activity changed to static reversals and eventually to rhythmical stabilizations in different ranges. It is possible to train proximal stability for distal movements by using timing for emphasis techniques. the patient is made to hold the proximal part of the patterns while moving the distal parts. Resistance is in these cases should be light as it is being used primarily as guidance. Gradually, the guidance should be removed and the patient left free to move by himself. It may be of value to use Frankel's precision exercises in these cases, and in fact, the principles of these can be added to the above account. Movements and patterns may be done to counting in a rhythmical manner, and even mat activities such as moving from side to side sitting to prone kneeling can be done to counting using markers on the floor as guides. When the ataxic symptoms are related to sensory loss as well as to hypertonia, the above suggestions are still applicable, but more care must be taken to help the patient with afferent stimuli. Frankel's approach may be emphasized more, still using patterns. Mirrors may be a necessity, and the patient must be allowed to use the eyes and ears as substitutes for other afferent information. Hard surfaces help this patient more than softly cushioned ones, and often the stimuli applied have to be exaggerated to have their effect. Movements carried out to counting or other rhythmical sounds are likely to be more successful than silent performances. All patients showing ataxia have to use cortical control for many of their problems, and this can hamper their activities since movement has to serious become a conscious activity instead of an automatic one. However, with continuous repetition, automaticity can be achieved, and automatic balance reaction should be encouraged to occur in a controlled manner. As the patient gains postural stability, he should react in a more controlled manner to gentle, unexpected disturbance of balance. Attempts should be made in all positions to get gentle reactions to body sway, controlled stepping reactions, and the use of the hands as a support in standing and sitting only as a last resort. So long as the hands do not have to be used for balance, they are free for skills. It is most important to note that many patients showing hypertonicity may also have an underlying tendency to adopt spastic patterns of movement, mass flexion, or mass extension. It is therefore most important to keep a wary eye on the use of volition to see that its excessive use is not encouraging the use of undesirable patterns. If it does, then emphasis on volition should be reduced and more automatic methods adopted to gain the same result. These patients should not be encouraged to use their upper limbs in pulling functions, since this may encourage them to use the arms in a mass flexor manner to pull themselves into standing. They will never gain balance in this way, and for this reason, such activities should be discouraged. Thus, such a patient, if confined to bed, should not be supplied with a monkey bar to help him to move around in bed. It will be encourage reflex patterning with which is undesirable. Functional activities. As with the lower motor neuron problem, functions with the capabilities of the patient should be encouraged. Suitable functions should be found relevant to the patient's ability. If good movement re-education is to occur, it is most important that excessive demands are not made upon the patient, since abnormalities will inevitably appear which might otherwise be avoidable. Walking will possibly be a goal, and this should be encouraged after the patient has the ability to balance in standing. At first, some support by the hands may be necessary using walking aids of some kind, and only when the patient is secure should he be encouraged to walk without using the upper limbs as balance mechanisms. It must be borne in mind that perfect functioning is unlikely in these cases, and the physiotherapist must be aware of the likely limitations. Occupational therapists and physiotherapists can often work well together with these cases, provided each respects the other person's aim for the patient. The goal must be discussed and reset as progress is observed. The patient's hopes must not be raised excessively, and every step forward must be noted by both the therapist and the patient. Every member of the team should be prepared to meet each problem as it arises, and no one should expect too much. There are other problems with these patients, but they will be considered under the appropriate headings since they are common to most neurological patients. Vertigo. Patients with this particular sensory problem have to learn to rely upon joint and skin sensation and those sensations from sight rather than those from the vestibular apparatus. As has been mentioned earlier, the giddy sensation and sickness are also accompanied by an active inhibition of movement, since movement of the head give rise to increase of the dizziness and nausea. The head and shoulder show rather a fixed posture and the patient is afraid of movement. Such is the link between eyes and vestibular apparatus that eye movements may even trigger off the symptoms. Thus, the patient need not be moving at all but could be watching a moving object, and would have symptoms similar to those which would occur if he had been moving. Re-education of this patient involves giving him confidence in moving and helping him to take notice only of the reliable sensory or afferent information. He should be treated at first in a fully supported semi-recumbent position so that head movements are unlikely to occur. Relaxation of the head, neck and shoulders should be encouraged and the patient asked to use his eyes only at first. His attention should be drawn to the sensation of the complete support that his position offers so that he is aware of the unlikelihood of moving at that moment. He should look at a stationary object which is a comfortable distance away from him and be asked to focus upon it. When he has it in full focus, the object should move slowly while he follows it with his eyes. If he feels dizzy, then he should close his eyes and feel the stationary condition of his body. At first, the object should only move as far as his eyes can travel, but as he progresses, head movements may also be involved, and later still, head movements with closed eyes should be encouraged in order to help him to rely only on joint and position sense. As he progresses, the patient may adopt less stable starting positions and exercise the eyes, head, and trunk progressively until he can move fairly freely without suffering from excessive symptoms. Gradually, he should progress to using hand or eye activities without losing his balance. Such activities as throwing and catching a ball in all directions are suitable. Standing and walking are advanced, and the patient must be made accustomed to having objects moving in relationship to him. It is particularly important that stairs are included in his treatment program, since the sides of the staircase can appear to be moving in the corner of the eye and can give vertigo symptoms in even quite normal people. As the patient progresses, he should be involved in group activities so that people and the things are moving about him at the same time as he is moving himself. This does, to some extent, prepare him for coping with crossing roads and traffic. His treatment is to complete without postural correction and mobility exercises of head, neck, and shoulder girdle, and at some stage he must be taken in among traffic on foot and given the confidence to cross the road. The problem of hypertonicity. Spasticity. As described in Chapter 4, the patient will demonstrate at least partial release of certain reflex mechanisms from cortical control and hence difficulty in producing movement patterns other than those produced by the released reflexes. The stretch reflex mechanisms will be extra sensitive, particularly in the patient dominated by the released reflexes. The normal malleable postural background will not be present, having given way to stereotyped patterns of the reflex nature. The patient will show poor vocabulary of movement patterns and of quality of control. There is frequently a lack of synergy, evidence of instability of joint control coupled with lack of righting and equilibrium reactions. The patient develops a pattern of spasticity related to the dominating reflexes. The reflexes most likely to exert their influence include the tonic labyrinthine, the symmetrical tonic neck reflex, and the asymmetrical tonic neck reflex. These reflex pathways are present in all of us, and by the process of maturation of the nervous system, their effect becomes integrated into the general control of all our movements. It is only when they are released from integration that they cause disturbance of movement pattern. A study of these reflexes will show that the position of the head and neck is very important, and that if care is taken to control their position and to encourage the patient to control it, excessive domination by the static postural reflexes can to some extent be avoided. Careful positioning of the patient can make management easier for the physiotherapist and the nurse, and at the same time make movement more possible for the patient. A study of the more dynamic writing reactions is also of extreme value. These reactions enable the individual to obtain the upright position, and the spiral movements of the head and neck, trunk, and limbs are related to them. It is thought that they may have an inhibitory effect upon the static postural mechanisms. The reduction in spasticity, which is seen to accompany trunk and limb rotation, may occur for this reason, although there is as yet no proof that this is so. However, rotation of the trunk and limbs when trying to reduce spasticity is a very valuable asset and emphasizes the importance of treating the whole patient instead of dealing only the offending part. When treating a patient who shows spasticity, it is necessary to carry out three important aims: inhibit excessive tone as far as possible, give the patient a sensation of normal position and normal movement, facilitate normal movement patterns. Inhibition of excessive tone. Earlier in this chapter, it was pointed out that inhibition could be facilitated as well as excitation. In case of spasticity, it is important to facilitate the patient's ability to inhibit the undesirable activity of the released reflex mechanisms. As has already been mentioned, the position adopted by the patient is important, since the head and neck position can elicit strong postural reflex mechanisms. Avoiding these head and neck positions can facilitate the inhibition of the more likely reflexes, and if the positions have to be adopted, then help in preventing the rest of the body from going into reflex pattern thus elicited may be required by the patient. The patient cannot, of course, spend the rest of his life avoiding the positions which encourage dominance by reflex activity, but at first this may be necessary until the patient has developed some control in the suppression of the effect of the reflex activities. As he develops this control, then he can be gradually introduced to the use of positions which make suppression of reflex activity more difficult. As an early introduction to treatment, the side lying position, well supported by pillows, is very convenient since it avoids stimulation of the tonic labyrinthine reflex and also has the head and trunk in alignment. The stimulation of the symmetrical tonic neck reflexes. It makes a good resting position for the patient with spasticity and also is convenient for the application of rhythmical trunk rotations of both a passive and assistive active form. These do help to encourage a reduction in tone. The scapula is also readily available to be involved in the movements. The upper and lower limb of the uppermost side are also easily accessible for any passive, assisted, active, or automatic movements which may seem suitable. Side lying is not always desirable because of respiratory problems in the older patient or because of the need to obtain a greater range of movement. Other attitudes are often very satisfactory, such as crook lying or even with the knees as high as the chest as possible. These last two are helpful if there is flexor spasticity. As the trunk is rotated, the legs are allowed to lower towards the extended, abducted, and laterally rotated position. For older patients, trunk rotation may have to be encouraged in sitting. Limb rotations are also very effective in helping to give a more normal control of muscles tone to the patient. These facts are of help not only to the physiotherapist but also to the nurse who may be concerned in moving the patient in bed or attempting to position the patient so as to avoid the development of deformities. The important factors in attempting to gain control over muscle tone are patterns of movement and posture associated with the release reflex mechanisms must be avoided and discouraged by position guidance and using the inhibitory methods mentioned in this chapter. Continuous which conditions which will facilitate control of tone should be given using the stimuli which will encourage normal patterns. As an example of the above 2 points, let us consider pressure applied to the undersurface of the foot. If it is applied to the ball of the foot, it may well stimulate an extensor reflex in which a pathological pattern of extension, adduction, and medial rotation of the hip is produced together with plantar flexion of the foot. This would be undesirable in a case of spasticity. If pressure is applied under the heel of the foot, then a more useful co-contraction of muscles is likely to occur, giving a suitable supporting pattern. The physiotherapist must become familiar with the stereotyped reflex patterning so that she can avoid permitting them to occur. It is most important that the physiotherapist becomes familiar with the patterning of normal movements and postures so that she can help her patient to move using in preference to spastic patterns. Help is needed to facilitate the movements by correcting weight distribution, head and shoulder positioning, and encouraging suitable rotational balance activities. For example, when walking, the right leg cannot be moved forwards unless the left leg is receiving weight correctly and the body is balanced over it. Trunk rotations normally accompany the mature walking patterns as reciprocal balance mechanisms and should be encouraged. Standing from sitting cannot occur unless the head and shoulder are brought well forward so that weight is distributed to the feet. As the patient rises, she may extend her neck and trunk too soon and throw her weight back to the side that she is not successful in reaching a standing position. The timing of neck and trunk extension may need to be assisted. All the necessary automatic adjustments are impoverished in these patients and help may be needed. Sometimes verbal help is needed, but more often actual assistance by simply adjusting the movements and waiting for the patient to react may be more helpful. This enables the patient to feel and perhaps see the successful activity at all times. The effect on the whole patient must be observed since it is quite possible to be gaining more normal tone in one part of the patient at the expense of another. Movement of a normal nature does appear in itself to reduce excessive tone and consequently this should be encouraged in patient. However, care must be taken if conscious volitional movement is demanded. Due to reflex release, some motor neuron pools are already in an excitatory state and any volitional effort is likely to act as a triggering mechanism to those motor neuron pools giving associated muscle contraction in the spastic pattern. Such patients should not be encouraged to make strong volitional effort since this is inclined to facilitate the production of spastic pattern. Conscious voluntary activity should be kept to a minimum until it is not accompanied by undesirable associated activity. Instead, appropriate stimuli should be given to encourage more normal responses, which will automatically help to reduce patterns of spasticity. Other methods of reducing spasticity include the application of heat or cold for relatively prolonged periods of time. These can have dramatic effects on some patients provided a large enough area of the patient is included. Total immersion in ice cold water has been recommended for some cases of multiple sclerosis who show spasticity, and the author has seen very impressive temporary results from this approach. The patient who responds to this shows a marked improvement in movement ability for several hours before the process has to be repeated again. Deep rhythmical massage with pressure over the muscle insertion has proved effective in some cases, and many authorities advocate slow, steady, and prolonged stretching. This last method does have its dangers, since if the stretching is forced against severe spasticity, the hyperexcitability stretch reflex reacts even more strongly, and damage to the periosteum of bone may occur where excessive tension has been applied by the tendons of the stretched muscles. Rhythmical, slowly performed passive movements through normal patterns may also be helpful, and in the more moderate cases, the patient may subconsciously join in, and by his own activity a reduction in spasticity may occur. Quick movements abruptly performed and noises surrounding are most detrimental, as are excitement, anxiety, or any form of discomfort. Sensation of normal position and movement. This is of vital importance. A patient who is dominated by reflex patterns never experiences the sensation of normal movement and position unless helped to do so. He is denied normal stimulation and either cannot know or soon forgets the normal. Very quickly, the abnormal feels normal, and vice versa. A patient showing extensive spasticity of the lower limb will almost will most often hold the limb in hip extension, adduction, and medial rotation, knee extension, and foot plantar flexion, that is, mass extensor synergy of the lower limb. Such a patient, when standing or sitting, may never be able to experience weight bearing and through the heel. When weight is taken from heel, the stimulus encourages a true supporting reaction, which gives co-contraction of hip, knee, and ankle muscles, flexors as well as extensors, in a malleable co-contraction suitable for normal weight bearing. Thus, there is no hope for the patient who is in extensor synergy unless some method of applying the more appropriate stimulus is found. If an abnormal position makes a starting point for a movement, then an abnormal movement must occur. Because of their spasticity, many patients are forced by circumstances to repeat abnormal movement patterns. By repetition, the nervous pathways used to cause these movements are facilitated, and the abnormal movements therefore occur more and more readily. When this has occurred, correction is difficult, if not impossible. Because of this, it is important to give early treatment to the whole patient so that as far as possible the sensation of normal movement is retained. If an abnormal position makes a starting point for a movement, then an abnormal movement must occur. Because of their spasticity, many patients are forced by circumstances to repeat abnormal movement patterns. By repetition, the nervous pathways used to cause these movements are facilitated, and the abnormal movements therefore occur more and more readily. When this has occurred, correction is difficult, if not possible. Because of this, it is important to give early treatment to the whole patient so that, as far as possible, the sensation of normal movement is retained. Patterns of movement to be encouraged. Praise for a movement should only be given if it really is good, because having received praise, the patient will try to repeat the same performance. If it was a good movement, the second attempt is also likely to be good. But if it was unsatisfactory at first, the repeated movement will also be poor, and this faulty pathway has been facilitated. Patterns of movement to be discouraged. Facilitation of normal movement patterns. More normal movement patterns can be produced when domination by reflex mechanisms is minimized. Thus, when the patient appears to be relatively free, movement should be encouraged. Movement itself will reduce spasticity if it follows normal patterns. Often, automatic adjustments of position is easier to produce than conscious volitional activities. Figure 7 by 2 and 7.3 illustrate some movements and positions which are helpful if encouraged and some which should be discouraged. Rotational movements of the trunk and limbs are important, and spiral rolling patterns involving head, shoulder girdle, and pelvis and limbs should be encouraged. In most cases, it is helpful to follow a neurodevelopmental approach with these patients. They often have a vocabulary of movement patterns less versatile than that of a newly born child. Thus, they are more likely to learn movement control if they are encouraged to follow the sequence of events seen in the movement patterning of a child. Basic functional movements are the ones to encourage at first. The child does not develop skilled hand movements until the hands are freed from being props for balance. The same holds good for adults showing spasticity. One does well if the upper limbs can be trained to support the patient. The ambition to train skilled hand movements should be deferred until this is achieved. It is important to appreciate that points 1, 2, and 3, page number 124, are best dealt with at one and the same time. In other words, when one does not arrange for the patient to fulfill the aim of reducing spasticity and then proceed to applying appropriate sensation and then re-educate movement. The patient should be placed in an area suitable for seizing the opportunity of moving as and when a reduction in tone is felt and as a suitable stimulus has had an effect. The physiotherapist must constantly observe the effect of her efforts on the whole patient, and if an opportunity arises to use a movement which is occurring in a normal manner, she should use it without delay. For this reason, a sample list of activities is impossible to offer since fixed methods are not applicable. Functional activities. It is in the field of spasticity that most controversy occurs regarding functions of daily living. If the aim is to normalize movement, only those functions which do not produce pattern abnormalities should be encouraged and progress should be made relative to this. The physiotherapist should, in this case, be the person to decide which functions are suitable. If, however, the aim is to gain functional independence at all costs, then movement abnormalities may have to be ignored or even encouraged in order to gain some sort of ambulation. Strictly speaking, the skill of a good physiotherapist should not be used for long if this is the aim, since well trained aides could fulfill it quite adequately with guidance. It is most important that consultants and therapists exchange views and come to an agreement on which line of approach is to be followed, and also when further attempts to help the patient are to be abandoned. Conflicting views can have seriously detrimental effects. Use of drugs. There are drugs available which will have an inhibitory effect on the stress reflex. These mainly work by blocking the synaptic functions of internuncial pathways. If they are effective, the patient is likely to be hypertonic with underlying movement patterns of the flexor extensor synergy. Such patients are best treated as hypertonic patients, but great care should be given if resisted exercise are used. Free active patterning with some automatic compression stimuli and gentle balance activities are more suitable. Rigidity. In this situation, the patient tends to show excessive postural fixation, axial rotation is non existent, and normal balance reactions do not appear to be available. The patient tends to adopt a fixed head and shoulder positioning, and movements which would normally be those of trunk rotation either do not occur at all or occur by the patient moving around as a whole. The face adopts a mask like rigidity, and the patient appears to be unresponsive to stimuli. A tremor is often present when resting, which disappears when purposeful movement occurs. All these symptoms are seen when the centers concerned with automatic reactions are the site of lesion, so that these reactions do not occur. Increase in tone causes opposition to all movements, which are therefore slow in being produced and are not readily accompanied by automatic postural adjustments. As in the case of spasticity, The abnormality effectively prevents the patients from experiencing normal sensory information, and he quite rapidly forgets the normal and accepts the abnormality as normal. The physiotherapist can help the patient in several ways, but she must always have the following aims at the back of her mind: to encourage a reduction in overall sensitivity of the stretch reflex mechanism, to help the patient to experience more normal reactions, to encourage movements to follow normal patterns in as wide range and as freely as possible. Reduction in overall sensitivity of the stretch reflex mechanisms. There are several methods available to achieve this aim, and the sooner the patient is treated, the more effective is treatment likely to be. Methods include teaching general relaxation in a comfortable, well supported recumbent position, the application of rhythmical massage of a sedative nature, and the use of rhythmical passive and or assistive active movements. The most effective method is likely to, to be to give rhythmical passive to active movements with the patient recumbent or semi-recumbent. The movements which are of the most value to the patient are those which are not available to him. Trunk rotations are particularly useful and may be carried out through a small range at first, gradually increasing the range and speeding up the rate of rhythm of the movement as the rigidity subsides. Such movements can be done passively by the physiotherapist, but she should not discourage the patient from helping if he can. It is not total relaxation that is wanted, but only a sufficient reduction in tone to make movement more possible. Probably the side lying position is a most convenient one for this purpose, since trunk rotations can be most easily produced in this position and can also be easily converted into rolling activities when the patient has enough freedom to do so. In addition, the patient's scapula is freely available and can be moved prior to encouraging greater range of activity in the whole body. Since many patients showing rigidity are elderly, the full recumbent position is not always suitable and rotations may have to be performed in other positions. It is quite possible to help a patient to rotate at the trunk in sitting by moving the upper trunk upon the lower, and one can even involve the trunk diagonal patterns of flexion with rotation to one side, followed by extension with rotation to the other. Limb movements can be encouraged in a similar way, involving the diagonal patterns if possible and starting with a small range and progressing to a larger range as the movement becomes more available. If the patient assists, so much the better. Experiencing more normal reactions. Helping the patient experience the more normal reactions is very much linked with the methods suggested in the previous section. As the patient loosens up with the when the overall tone of the muscle is reduced, opportunities to react to situations should be given and help to reach and experience the reactions should be offered as needed. For instance, if trunk rotation is being encouraged in sidelining, the patient will gradually loosen up and start to participate. The upper limb should then be encouraged to come forward to receive weight as the trunk comes forward, ready for going into prone lying. If the limb does not react automatically, the therapist can repeatedly encourage rotation and bring the patient's arm and hand forward into the supporting position. Gradually, the patient will appreciate the sensation and will join in until all the physiotherapist need do is gently push the shoulder forward to initiate the reaction. A similar method of encouraging the appropriate lower limb reactions may also be used. If the trunk rotations are being done in sitting, other balance reactions may be aided. Such reactions as hand support forwards or hand support sideways may be encouraged. Even the lifting reactions of the limbs on the side away from which the patient is shifted can be helped by the skilled physiotherapist in this way, so that the patient experiences the sensation of balance reactions. By lifting reactions are meant the reactions of the body to displacement of weight sideways or backwards. If the body weight is displaced sideways, the upper limb on that side moves sideways to receive some of the weight. The other upper limb lifts sideways to try to pull the body back to its original base. The lower limbs, if free, may also participate by rotating. Figure 7 by 4. Any sign of regression back into rigidity to an excessive degree should be countered by further rotations. Trunk rotations with rhythmic arm swinging can be very helpful and give arm swing sensation required when walking. Many physiotherapists encourage this by having the patient sitting or standing, holding one end of a pole. In each hand, the physiotherapist is holding the other ends of the poles, and using her arm swing, she can encourage the arm swing of the patient. Encouraging movements to follow normal patterns in a wide in as wide a range and as freely as possible. This automatically links with the previous two sections and has to some extent already been encouraged. Movement patterns may be encouraged with minimal resistance for guidance. The range should be small at first and slowly encouraged to larger range and faster movements. The patient has to be pumped up to more rapid and fuller range of activity. This also applies to functions such as standing up and sitting down, rolling over and getting started with walking activities. For the younger patient, the author has found the following type of activities most successful: rhythmical rolling in a spiral manner, first helping the patient and later starting the movement for the patient and allowing him to react by following, encouraging the adoption of side sitting and moving on to all fours and then sitting on the opposite side. This is started on all fours and the patient sways rhythmically towards the side upon which he will eventually sit before rising back to all fours. At first, he does not sit at all, but gradually approaches the sitting position as a fuller range is available. This activity encourages trunk and limb rotation, and if rhythmical, it will help to keep the overall tone reduced. Rhythmical crawling may also be encouraged by swaying the body weight forwards and backwards and eventually encouraging a step forward reaction of the limb. Hand support, forward half kneeling, changing legs rhythmically may also help and eventually leads to the adoption of standing. The standing activity should include rhythmical walking, which is best started by rotating the trunk at the shoulder so that an easy arm swing rhythm is started. The patient's body weight is then pushed gently forwards at hip level to encourage a stepping reaction in the lower limbs. The customary stooping position should be avoided and the patient encouraged to maintain as upright a position as possible. Many physiotherapists use poles, as mentioned previously, to initiate walking and do so by encouraging the patient to step forward with the right leg as the left arm comes forward. Gradually, the walking should include turning and stepping backwards and also across the other leg. These activities may be done as conscious volitional activities, but if possible should eventually become an automatic response to disturbance of balance. One cannot do quite such agile activities with the older patient, and some of the following suggestions may prove helpful. Sitting, assisted active trunk rotations to encourage a hand support sideways sitting position, hand supporting to one side. Encourage standing up by leaning back to leaning forwards and standing up. Rhythmical swaying may be more suitable at first and then gradually changed to standing up. Standing up to sitting down as before, progressing to standing up again with the hands supporting to alternate sides. This also involves trunk rotations, which are so easily lost in these patients. Arm swinging and walking can be encouraged as in the younger person. In both types of patients, limb patterns through full range should be encouraged in addition to functional mat type activities. Patients' relatives can be taught to help reduce the rigidity at home by encouraging rotational movement and perhaps helping to give the necessary pumping up procedures prior to achieving a particular function. It is most important to keep these patients as functionally independent as possible, and relatives must be encouraged to give minimum assistance of an educated nature. The patient can help himself to a tremendous degree once he receives adequate guidance and provided he receives appropriate encouragement from his relatives. It can be helpful to allow him to have a period of intensive physiotherapy at intervals and to encourage him to be responsible for his own welfare, movement wise, in the periods when he has no formal treatment. An early morning warm up exercise session involving trunk rotations and rhythmical swinging movements of arms and legs can be very valuable when he is otherwise receiving no treatment. Odd jobs about the house which require movement are more suitable than those which can be done sitting down. They may take a longer time for the patient to perform, but they are a treatment in themselves. Static activities are undesirable and rhythmical stabilization do not usually help these patients and so should be avoided if possible. Drugs are available to reduce rigidity, and some surgical procedures have given a measure of relief. The patient may then show variable movement problems and has to be dealt with according to individual peculiarities. It cannot be emphasized too much that the earlier the patient receives treatment, the more effective it will be. When a patient is first suspected of showing rigidity, some symptoms he is unlikely to show gross abnormality and will not have so much underlying joint stiffness or have forgotten normality to such a degree. He is therefore more able to be receptive to help. This is directed at helping him to help himself. He may then well be able to minimize his symptoms more effectively for longer. If the patient is very rigid when he first receives help, he may also have painful joint stiffness and have mechanical difficulty in addition to physiological problems. Normal movement will be very unusual to him, and the likelihood of his being able to help himself adequately is considerably more remote. The problem of acidosis, chorea, and barosmus. These three movement abnormalities are grouped together since all show the presence of involuntary activity and fluctuations of tone. The physiotherapist has to meet problems with these patients when they appear. At one time, she may be required to encourage stability in the same way as she would a hypotonic patient, and at another time, she may have to help in the inhibition of abnormal activities while encouraging normal purposeful movement patterns. Excitement should be avoided at all costs since this increases the symptoms. Athertoid patients frequently have problems with body image, and steps must be taken to improve this by experiences of normal activities and stimuli. Many athertoids are helped in stability by compression forces being applied through weight bearing joints. Some children benefit by wearing little leaded caps which add to the weight of the head and give compression force to the vertebral column. This helps to stimulate stabilization. Much of the action advised in preceding sections is useful for these patients, and the physiotherapist must use her ingenuity in selecting those activities which help and discarding those which does not. She must receive a constant feedback from the patient and adjust her stimuli accordingly. Drugs and surgery have been used to control the symptoms of these disorders and have met with varying success. In such circumstances, the patient is still left with the movement abnormalities which have to be assessed and treated accordingly. Biofeedback equipment, as mentioned at the end of chapter 6, may also be of value to the therapist treating problems discussed in this chapter. The signal of muscle activity can be used to indicate successful patterning to the patient, or more negatively, it can be used to indicate unwanted activity. Problems of deformity. Adaptive shortening of soft tissues is likely to occur when habitual posturing is adopted by patients who have any idea or disease who have any disease or injury problem. In neurological problems, it is particularly likely to occur when no movement is available to the patient and when there is imbalance of muscle pull. There are many methods of preventing the onset of deformities of this nature. These include passive movements. These were already suggested in an early section as being helpful in maintenance of a knowledge of body image. When used to prevent deformity, the physiotherapist must bear two facts in mind. She must maintain the biological length of the muscles which work over the joints she is moving. This means that her passive movements must involve elongating the muscle over all its movement components. For example, to maintain the length of gastrocnemius, she must dorsiflex the foot and extend the knee, and her return movement should be plantar flexion of the foot and flexion of the knee. In that way, she has fully lengthened gastrocnemius, which pulls over the back of the knee and ankle, and she has also put it into most shortened position. She must maintain the biological pliability of the ligaments of the joints she is moving. This means that she must be cautious when moving a joint over which a two joint muscle works, since it could restrict the range of movement available before the ligaments are fully elongated. For example, ankle dorsiflexion is limited by gastrocnemius if the knee is held extended as the ankle is dorsiflexed. Therefore, the ligaments of the joint are not fully elongated by the time movement has stopped. Thus, in this case, the tension should be taken off gastrocnemius by flexing the knee before dorsiflexing the foot. A greater range will then be found to be available. Careful positioning of the severely disabled patient. This should be done in such a way that constant adoption of the one position is avoided. Limbs and trunk should be supported in a variety of positions throughout the day. Extreme positioning of any joint should be avoided. Splintage. This is most helpful in patients with peripheral problems as it prevents the flaccid muscles groups from being constantly stretched by normal opposing muscle action. Splints should never be left on permanently but should be used as resting splints when the patient is likely to adopt a prolonged poor position of the joints concerned. Lively splints are very useful since they allow movement to occur and simply return the limbs to a normal position at the end of the movement. They are more functional than the simple rest splints. Many people use splintage with central nervous system problems, but it should only be used in certain well-considered circumstances. Splints applied to such cases effectively prevent normal movement patterns, and pressure from the splint may actually increase the spastic patterning. For example, a plaster cast applied to the lower leg and foot to keep the foot in dorsiflexion may effectively stimulate by pressure on the ball of the foot an extensor response which will take the form of a mass extensor synergy. This could be undesirable and worse than no splintage at all. Only in some circumstances is splintage helpful in these disorders. Use of bed cradles. These are very helpful. They lift the weight of bedclothes off the limbs which may be paralyzed, and therefore the bedclothes do not force the feet into plantar flexion. The cradle is also useful when hypertonicity is a problem, since the constant irritation of bedclothes can stimulate withdrawal reflexes which encourage flexion deformities. If deformity is already present by the time the patient comes for help, the problem is much greater. The patient may require more help to counter the problems such as traction, manipulation, and surgery. In the latter case, tendons may be divided and lengthened of muscles are disattached and left to reattach in a more suitable position. The physiotherapist may be able to help in some cases by the application of serial plasters designed to correct deformities gradually. Some patients, particularly those with lower motor neuron problems, develop adaptive shortening of the muscles antagonistic to those which are paralyzed. The physiotherapist can help considerably here to encourage a new resting length for these muscles by using any or all of the following methods. The application of prolonged about 20 to 10 to 20 minutes cold packs to the adaptively shortened muscles. The packs must extend over the whole length of the muscle. This method encourages inhibition of the muscle, which will relax more, making it possible to lengthen it more easily. The use of hold relax techniques, in which the adaptively shortened muscle is put into as elongated position as is comfortable and then made to contract statically, hence the term hold. As the contraction is held for the prolonged time, it begins to weaken. When this occurs, the patient is instructed to relax while the physiotherapist supports the joint or joints involved. When relaxation has occurred, the physiotherapist further elongates the muscle passively. If successful, she will find that the muscle will allow itself to be elongated more as it has relaxed sufficiently to allow an increase in length. There are various theories as to why this should work. Some authorities say that the muscle relaxes more because of fatigue, and others consider that the Golgi tendon organs, which lie at the musculotendinous junction, are stimulated by the contracting muscle pulling on the tendon. As was stated earlier, these organs have an inhibitory influence on the motor neuron pools of their own muscle and may therefore help to induce this excessive relaxation, autogenic inhibition. Cold packs may be applied at the same time as hold relax techniques. Hold relax is most suitable for use when adaptively shortened group are opposed by completely flare antagonist. A modification of the above is the slow reversal hold relax technique. In this, the procedure is as for hold relax, but after the relaxation stage has occurred, the patient is stimulated to use the antagonist to adaptively shorten muscle concentrically. In other words, the adaptively shortened muscle is made to contract statically by a hold. It is then commanded to relax, and the reverse movement is brought about by active concentric activity of its antagonist. This activity is most useful when there is some activity available in the antagonist. The phenomenon of reciprocal inhibition is added to the phenomenon of autogenic inhibition in this case. The above techniques are only of value when movement limitation is due to changes in length of muscle. They do not help if the limitation is due to ligamentous or bony changes. Some workers claim to have used the above techniques to relax spastic muscle groups. The author does not use this particular technique for fear of facilitating spastic patterning. The student should, however, keep an open mind in all such matters and decide for herself which method she will use, noting the results and accepting those which give good results while rejecting those which do not. Prevention of injury, that has been largely dealt with on page number 98, since much of the damage which can occur in these cases is due to sensory loss. The patient must be made aware of the dangers if possible, and if he cannot change his position himself, he must be frequently turned. He must be kept scrupulously clean and have his skin toughened and protected against the possibility of pressure sores. If any area shows signs of breaking down, it may be stimulated by ice massage to improve the local circulation, or by heat or mild doses of ultraviolet light. The use of heat has its dangers, since sensory loss may make the patient endure a temperature that is too hot for safety. Cold is therefore the method of choice. The use of ripple mattresses, sheepskins, protective rings, and constant changes of position should effectively prevent the onset of sores. If they do develop, they are very detrimental to the patient's general condition and must be treated as serious a problem. Circulatory problems. Many patients show disturbances of circulation. Some of these are due to lack of movement, and some are due to disturbance in some part of the autonomic system. In lower motor neuron problem, the loss of muscle pump activity will cause slowing of the circulation through the affected area, and in addition, the peripheral autonomic nerve fibers may also be involved. These problems can be helped by encouraging activity in other parts of the body. This will speed up circulation generally. Whirlpool baths for the affected areas may also be used. These will promote circulation to the skin over the affected muscle groups. Contrast baths may also prove valuable. They may stimulate such blood vessels activity as is available. The central autonomic problem is well described in chapter 8. Essentially, the patient has to adapt gradually to change of positions, which puts greater demands upon the problem of maintenance of blood pressure. In case of causalgia, in which there is disuse due to pain, similar methods may be used to those advocated for the lower motor neuron problem. Wax baths may also help here, but on the other hand, they may cause onset of pain and should be used with reservation. Many patients who have hemiplegic symptoms have problems in the posturing of the shoulder girdle. This can cause pressure and kinking of the axillary vessels, giving rise to edema, which is further encouraged by lack of use and the dependent position. In this case, the weight of the limb may have to be relieved by sling support to reduce pressure on the axillary vessels. This is unfortunate since it discourages movement of the limb. However, the sling need to be retained all the time, and other treatments for edema may be given which involve movement. As soon as the posturing of the patient improves, the sling should be discarded. Respiratory problems. Many patients show respiratory problems. These range from those which are due to paralysis of the muscles of respiration to those which are due to restriction of exercise because of the patient's disability. Patients who have paralysis of the respiratory muscles will obviously need the help of a ventilator and will be in an intensive therapy unit. They may also require to have assisted coughing or may even need suction to help to remove secretions. Only the local peripheral problems will totally escape from respiratory difficulties. The head injury case may well require tracheostomy, suction, and to be ventilated (IPPV). The patient with a central nervous system disorder of the progressive variety will be inclined to develop respiratory distress as the disease progresses. The muscles supporting the thoracic inlet may be hypotonic and will allow respiratory movements to have a suction effect on the chest wall in this area, thus diminishing the amount of air the thorax can house. Such patients may also have deglutition problems and it is possible for food to be inhaled. Even the less handicapped patient may show weakness of respiratory movements and will need some help. Breathing exercises should be incorporated into the treatment of all the heavily handicapped patients. They may be facilitated in lower motor neuron cases by using appropriate arm patterns and by giving repeated contractions to the muscles of inspiration. Both inspiratory and expiratory phases should be emphasized to get maximum respiratory excursion. The central problem requires a more relaxed approach, but respiration must not be forgotten. It is particularly important to the rigidity case and to patients with multiple problems like multiple sclerosis. The advanced case of multiple sclerosis and also the patient with weakness in the thoracic inlet and deglutition group, homohyoid and mylohyoid, digastricus, thyrohyoid, and sternothyroid may be helped by giving head and neck patterns of a resisted nature, stabilization of the head and neck, and combining these with respiration. Problems of speech. These problems are properly left to the speech therapist, who is the specialist. The physiotherapist may be able to endorse the work of the speech therapist if the two team members can discuss matters with each other. It is possible to stimulate movement of tongue by using a spatula and moving the tongue with it, encouraging the patient to participate. Ice frozen onto the spatula may also help as cold as a stimulus. As the water forms from the melting ice, it acts as a lubricant to the tongue and mouth. Activity of buccinator can also be encouraged by pressure from the spatula against the inside of the cheek. This may help to train the patient to keep the cheek against the teeth and therefore prevent collection of saliva. This can be very useful when treating facial palsy, as the stretch stimulus can be used by pressing cheek outwards while commanding the patient to pull it in. Speech in the severely handicapped is not easily available unless there is control of head position, and the physiotherapist may be required to help in this way. Deglutition is also difficult without head control and may be impossible if the patient is recumbent. The patient who has swallowing difficulty should be fed, if possible, in an upright position. To speak, we also have to be able to swallow, as otherwise we spit as we speak. The swallowing muscles may be stimulated by stroking or brushing over the anterior aspect of the undersurface of the chin and neck by icing the tongue and lips. Exercise tolerance. This becomes lost if respiration and circulation are impaired, but it may also be lost due to disuse. The wheelchair patient never fully uses himself unless encouraged to do so. If possible, he should be encouraged to indulge in as active a type of exercise as possible to maintain good exercise tolerance. Other patients should be given activities in their program which tax them to their limits, that they maintain good general health. The only expectation to this would be perhaps the patient who has had a cerebrovascular accident or one with the cardiac complications. Care must be taken to see that patient and relatives understand that to be overweight is detrimental. The less exercise the patient is able to indulge in, the lighter should be the diet. Overeating is a common problem to the handicapped patient. Pain. This, as has been stated before, is a problem most associated with irritative lesions. Relief of the irritation leads to a relief of the pain. Pain may also be the result of faulty posturing or of faulty muscle synergy leading to inflamed bursae, etc. Pain relieving methods include gentle heat to encourage relaxation, cold, which often helps when heat fails, soothing massage techniques associated with correction of malposturing, and the use of movement activities which help to reduce discomforts of constant joint positioning. Many patients who have loss of synergy in the shoulder have severe shoulder pain which spreads down the arm. The hemiplegic patient is particularly prone to this. The pain can often be relieved by the application of cold pack over the shoulder area incorporating pectoralis major, deltoid, and the scapula. If this is followed by rhythmical traction versus compression stimuli, the patient frequently reports relief of pain. The explanation for this is obscure, but it may be that the cold helps to relax the painful muscle spasm, which will superimposed upon the patient's other symptoms, and the compression alternatively with traction may stimulate the more normal muscle synergy and therefore joint protection. If the pain is part of a neuritis, the position of the vertebral column and shoulder girdle is important. Cervical traction may be advised as a measure to relieve pressure on the nerve roots and therefore act as a relief of irritation. The pain of causalgia is another difficult problem, and all pain relieving methods may be attempted. Heat is not always successful and may be dangerous if the patient's ability to appreciate degrees of heat is impaired. Thalamic pain is not very responsive to physiotherapy, and drugs may be the only thing to help the patient. Drug therapy is used widely in the relief of pain, which cannot otherwise be helped, and even surgical interference may be attempted as a method of blocking sensory input of a painful nature. Loss of consciousness. Patients showing loss of consciousness require special care in an intensive therapy unit. Attention must be paid to the accompanying respiratory problems, and the physiotherapist may be called in to help in these matters. As was indicated in Chapter 4, there are various levels of unconsciousness, and much care must be taken to talk to the patient and not about him in case he is receptive to some stimuli. Epilepsy. Fits of this nature are usually held in check by administration of phenobarbital and allied drugs. The physiotherapist must know whether her patient is prone to these attacks so that she is not completely unprepared should one occur during a treatment session. If the fit is of a minor nature, it may pass almost unnoticed, but if it is of a more major type, then care must be taken to prevent the patient from injuring herself and other people. Such patients should not be left unattended, nor should they be treated in areas where they could come to any severe injury should they have an attack. Pool therapy may well be unwise for these patients on two counts. First, there is a danger of inhalation of water and possible drowning. Second, the shimmering effect of light on the water may well trigger off an attack. Epilepsy can be triggered off by light wave bands giving visual stimulation, and for this reason, some patients show the onset of an attack if they sit watching television for long. This is particularly likely to happen if they are too close to it and in a darkened room. The flickering light coming through trees and from a road upon which there are multiple areas of shade and light may also be a contributory factor, and patients who are traveling as passengers are advised to close their eyes when the light fluctuates in this way. Shortwave diathermy has been shown to have a similar effect, and care should be taken if such treatment is contemplated for any patient known to have epilepsy. It is as well for the physiotherapist to know this since patients often complain of feeling unwell or of having mild attack when watching television. The physiotherapist may be able to help by explaining the cause. Incontinence of urine and back pressure. As was explained in Chapter 4, many of the more severely handicapped patients show these symptoms. Catheterization is standard with method of dealing with this, but unfortunately it often leads to urinary infection which have to be controlled by antibiotics. Back pressure into the kidneys can be relieved periodically by allowing the patient to adopt the upright position for periods during the day. If the patient is unable to stand, he may be supported on a tilting couch which can be wound up into the upright position. The patient may have to be secured by strapping into position, but provided adequate padding is given, there is no danger of skin pressure. The method of procedure can be useful for patients suffering from multiple sclerosis who has reached the bedfast stage and who is in danger not only of having urinary problems but also of going into a flexion position. The weight-bearing stimulus through the feet encourages extension and contracts the flexion, while the urinary complications are minimized. The patient may be held in this position in the gymnasium, which is a change from the ward, where he may have free use of any movement available in the arms and where he can make social contact with other patients. This may seem to be of small value, but values must be related to the situation of the patient. If left, he would be curled up into flexion at this stage, have kidney failure, pressure sores, and be unable to make any social contacts. The remaining weeks would be spent in more discomfort than necessary. Functional independence. At some stage in his rehabilitation, the patient will require help towards functional independence. Exactly when this is encouraged will depend upon the type of condition and the method of management being used. To be manageable at home, the patient should be able to move himself up and down and about his own bed. He should be able to transfer himself from his bed to a chair of any kind, and if he is a wheelchair patient, he should be able to maneuver the wheelchair about the house and transfer from wheelchair to toilet seat into the bath, etc. All these things should be possible with minimal assistance from relatives. In some cases, special hosts have to be supplied to patients to help them to be independent, and aids have to be given to make some functions possible. It is, however, the most important that aids are only supplied as a last report as an intermediate measure from which the patient will progress. The physiotherapist and occupational therapist are involved in functional independence and should work in close conjunction with each other. Such activities as dressing and washing must be related to the patient's ability to balance in various positions and to carry out fine movements of the hands. Although the occupational therapist is very involved with this aspect, the physiotherapist must also take an interest, since she is probably responsible for the balance training and will know when the patient can be expected to use hand skills. For the housewife kitchen, training is dealt with as a rule by the occupational therapist, who is concerned with any adaptation required for patient's own kitchen. However, the physiotherapist may well be able to help by giving the patient the necessary skills of movement so that she may use her kitchen either as it is or with its adaptation. Home visits may be necessary and should be made ideally by the occupational therapist and the physiotherapist together. Much of the patient's treatment program can be adjusted to suit the particular home problems, and the physiotherapist gains much by seeing the difficulties likely to be faced by the patient. In some cases, functional independence cannot be achieved without some kind of aid, such as a weight relieving or weight bearing caliper, a pair of sticks, elbow crutches, or a wheelchair. The patient must be correctly assessed for these appliances and must also be adequately instructed in their use. The education of relatives is important. When the patient is sent home, the relatives have an all-powerful position and can make or break the patient's progress. They need help to understand the problems faced by the patient and to know how best they can help him. If they smother him with help, they may make him relinquish his independence, and then he will be wholly dependent and become a burden. If they offer too little help, life may become too difficult for the patient and he will give up trying. Thus, the relatives have a considerable responsibility when the patient finally goes home. Finally, the need to get out and to see other people is very great, and relatives and patients alike must appreciate that confinement to four walls eventually imprisons the mind. Herein lies a great problem. Handicapped people often rely upon others to help them to get out, and if they do not get away from hope, they become fractious and difficult since their horizons become narrowed. The opening of the day centers for severely handicapped patients helps a great deal. Patients who have been away from home for a day meet their relatives in the evening with refreshed minds and have something to offer as a social contact. Naturally, it is hoped that patients will be able to work, but those who cannot must be forgotten, and it is for these patients that day centers are most value.